Suppose most of you must have guessed the Castleman would pertain to talking something on Castleman disease, but the Krebs, I'm guessing that also you guessed, it's the Krebs cycle. So that's something that we learned in biochemistry, right, in first MBBS. Why am I discussing Krebs cycle here today? So a lot of enzymes involved in the Krebs cycle, which are actually oncometabolites now. All of us know the story of IDH1, so that's isocitrate dehydrogenase. The success story for IDH prognostic in brain tumors. It's also involved in, we saw today with IDH1 nasal tumors and also for biliary tract tumors. But there are two enzymes which I'm going to focus on today. One is FH, that's fumarate hydratase, and succinate dehydrogenase. A little bit on the person who actually described this cycle is Sir Hans Krebs. He's actually German, but a British citizen, and therefore he was knighted for his contributions. He was a pioneer scientist in the study of cellular respiration, and he is best known for his discoveries on two important sequences of chemical reactions, the tricarboxylic citric acid cycle and the urea cycle, and he also received a Nobel Prize for discovering this. It's eponymously named after his name as Krebs cycle. Now, little did anyone know that one day the enzymes involved in Krebs cycle would explain oncogenesis. So a fumarate hydratase is an enzyme that catalyzes the reversible hydration, as it names its hydratase, of fumarate to malate. And it's used by organisms that actually do aerobic respiration as opposed to the ones which actually ferment, that's anaerobic respiration. Now mutations in the gene which encodes the fumarate hydratase enzyme, that's a protein, have been associated with the development of leiomyomas in the skin and the uterus, and in combination with renal cell carcinomas also. And in total, this syndrome is called the hereditary leiomyomatosis and renal cell carcinoma syndrome. A little bit of what happens when there is FH deficiency in the cell. You have difficulty in metabolizing fumarate, and therefore intracellular levels of fumarate increase. This results in some compensatory metabolic shifts. The mitochondrial oxidative phosphorylation is reduced because if you remember from your biochemistry days, the Krebs cycle actually provides a substrate for the oxidative phosphorylation, so that becomes reduced. At the same time, there is increase in aerobic glycolysis, there is catabolism of the glutamines, and there is increase in anabolic proteins. So these are all actually features of the Warburg effect, and Warburg effect is something which is very active in cancer cells. Now, elevated intracellular fumarate is also believed to inhibit enzymes which actually degrade the hypoxia-inducible factors. So once it's inhibited, what happens is the hypoxia-inducible factors are stabilized, leads to increased EPO and increased VEGF, which are actually responsible for cancer, particularly renal tumors. Now, increased fumarate levels also result in post-translational succination of cysteine residues, or the protein residues, and you can use that phenomena to use 2-succinocysteine, that's a 2-SC, as a biomarker to understand there is a FH deficiency in the tumor cells. So this is just what I explained to you just now. So how is it useful to us as pathologists? Now, tumor morphology can be used to identify FH deficiency in uterine smooth muscle tumors and thereby direct patients to formal genetic counseling. The low magnification clues of staghorn-shaped blood vessels, alveolar type stromal edema, and plexiform nodular pattern should prompt for a high magnification for eosinophilic cytoplasmic inclusions, oval nuclei containing prominent eosinophilic macronucleoli, and a halo around these nucleoli. Now, let me kind of clarify, none of these features in isolation show any perfect diagnostic accuracy, but their conspicuous presence within a tumor should prompt further consideration that one is dealing with a FH deficient tumor, particularly if you're dealing with a young lady. So this is one image of a hysterectomy for fibroids. We get it on our tables. I mean, how much importance do we really give to it? You look for mitosis, and if there's no necrosis, you're all happy just calling it a benign leiomyoma. But look at the morphology here, and if you can appreciate on the left side, you can see the vague nodularity to it, plexiform nodularity. On the right side, you can see some HPC-like vessels, and I'll show you the next picture, which is much better. And you can see this symplastic nuclear atypia. When you see all these things, try also scanning at the high power, try the other scanning views, and also go to the high power. You can see this very alveolar type edema. You can see this pale areas amidst this leiomyoma. You can see this branching HPC-like vessels. And then you start seeing this nuclei which have that symplastic look, but within them, if you can identify, you can see this, I'm going to mark with this, look at this internuclear inclusions. And likewise, there's a huge macro inclusion here, but also there are nucleoli, prominent nucleoli with a perinucleolar clear area. And you can see, once you start seeing them, you'll start noticing them in a lot of these sections. And here the other areas where I've highlighted that, so you can see there's very prominent internuclear inclusions, perinuclear clear area. If you start seeing all of these, think about an FH deficiency. So this is positive for Desmin and SMA. Tells you it's a smooth muscle tumor. And here's the FH stain. So it's marking the blood vessels and the bystander lymphocytes, but it's completely lost in the lesional cells. So the wild type staining would mark all the cells. In this case, because there is a deficiency of FH, the tumor cells show loss of expression. Now, multiple areas in this lesion again showed similar symplastic-like nuclei, prominent nucleoli with a clearing around the nucleolus, and loss of FH by immunohistochemistry. And here's for comparison, this is how a FH wild type would look. Almost everything would mark with that stain. So on diagnosis, this is an FH deficient leiomyoma. The patient should be investigated for cutaneous smooth muscle tumors and a possible renal tumor as well. And it has implication in the family for genetic testing as well. So this syndrome, the HLRCC, is an autosomal dominant syndrome and results from germline mutation in the FH gene. There's an associated risk of smooth muscle tumors of the uterus and skin and renal cell carcinoma as defined in the syndrome. RCCs can develop in about 1/4 of these patients. They are often present in the 4th decade and are high-stage aggressive tumors with poor clinical outcome. A majority of these were typically collecting duct carcinomas or papillary carcinomas type 2. And of course, this predates the WHO recent classification, which no longer calls anything as papillary type 2 RCC. But those are the common ones which are associated with this syndrome. So most women with this syndrome develop large and bulky uterine smooth muscle tumors early in their lives, in the 2nd and 3rd decade. You tend to see them a little bit later, but when you get it early, think of this syndrome. And here's something very amusing. I mean, FH mutations occur rarely, if at all, in association with true leiomyosarcomas. So that's the vagary of oncogenesis. It will probably lead you to a leiomyoma, but it's seldom, or even, actually it's never been described that it causes leiomyosarcoma. So the learning points, very inane morphologic features led to a suspicion for FH deficiency. It has implications not only for the patient, but for the family as well. Morphologic, as with everything in life, you don't stick to IHC for everything. You have to look at morphology first. So morphology backed by a next generation IHC in this case led to a diagnosis of, something beyond a simple leiomyoma. Now, loss of staining for FH may be considered a reassuring finding in an atypical uterine smooth muscle tumor, the ones which we think are stumps, for example, where you get that symplastic nuclear atypia. And if you do get that FH retained, you should be fairly hesitant to make a diagnosis of uterine leiomyosarcoma. So that are the learning points from this case. I'll switch over to the other enzyme in the Krebs cycle, the succinate dehydrogenase. It's a respiratory enzyme composed of 4 subunits, A, B, C, and D. Now, good for us because when you do the SDHB immunohistochemistry, if there's a loss in any of the subunits, the SDHB is also lost. Now, tumors which show loss of SDHB expression are termed succinate dehydrogenase deficient. I won't bore you with the entire cartoon here, but focus on the one right at the bottom where it says succinate being kind of changing to fumarate by the succinate dehydrogenase. If you have a mutation in the gene which encodes this enzyme, you have backup of succinate that leads to, again, stabilization of the hypoxia-inducible factors, leads to increased VEGF and EPO, that's the erythrocyte EPO enzyme which leads to increase in the RCC, and that's the whole mechanism which happens with SDH deficiency. So although SDH complex is essential for life, haploinsufficiency is tolerated and compensated, which means that even if you have one gene which is at defect, it's fine, the body will compensate for it. But if you have a combination of this one germline mutation and a second hit in terms of a somatic hit, that causes an SDH deficiency. Sometimes mechanism is not clear and perhaps an epigenetic mechanism causes it. So what are these SDH deficient tumors? About 15% of pheochromocytomas and paragangliomas are associated with SDH deficiency. And about the 3% of gastrointestinal stromal tumors are SDH deficient. Why are they important to recognize? So while they express KIT and DOG1 by immunohistochemistry, they do not have the KIT and PDGFR or any of these common mutations. So which means that they are not sensitive to imatinib. They, for some strange reason, almost have an exclusive gastric location. They're typically epithelioid morphology. And while we give the prognostication for most gastrointestinal tumors in terms of their size and mitotic activity per 50 high power fields, that's not the case with SDH mutant GIST. They frequently metastasize to lymph nodes. And as I said, because they don't have a KIT or the PDGFR mutation, so they would qualify as a wild type GIST. They are resistant to imatinib. But overall, clinically, they behave indolently. There's also an entity called SDH deficient renal cell carcinoma in the new classification. Less than 1% of the tumors are SDH deficient, and they have vacuolated eosinophilic cytoplasm and internuclear cytoplasmic inclusions. Very rarely there are pituitary adenomas, and even Sertoli Leydig cell tumors have been described in association with SDH deficiency. Now, between a quarter and a third of paraganglioma cases have familial histology, etiology rather, so they may be associated with the von Hippel-Lindau or the MEN2, NF1 or the SDH mutation-related tumors. Why is it important to recognize this SDH deficiency? Is because head and neck paragangliomas with these mutations have a high risk of metastasis. About a third of these patients by the age of 70 years will develop a metastasis, and mainly that will be in the regional cervical lymph nodes. So here's an image of a very typical paraganglioma, nothing to kind of describe here, very Zilberman pattern. And you can see it's marking with synaptophysin, and SND is highlighting the sustanticular cells. By the way, this happened to be in the retroperitoneum and not in the head neck region. Here's INSM1, which also shows you that they are neuroendocrine cells. But what's very interesting here is the SDHB is a mutant type IHC here. You can see the expression levels in the bystander lymphocytes, which is bright, and complete absence in the tumor cells. Now, how do you recognize? So there's something very specific about the paraganglioma. You won't be able to have a pointer to look for it. So you'll have to just do the immunostaining. But for a GIST, what are the pointers to actually do SDH staining? When you have a young patient, when you have a gastric location, when you have an epithelioid morphology, all these things should ring a bell about a possible SDH mutation. So as I said, with IHC, KIT and DOG1 will be brightly positive. And if you have the germline SDH mutated GIST along with the paraganglioma, that's called the Carney-Strateky syndrome. So here's an epigastric nodule in a 25-year-old male. This patient apparently had a gastric GIST in the past. This seemingly was a recurrence in the epigastrium. Somebody actually kind of correctly called it. It's an epithelioid GIST with marking for CKIT and DOG1. And you wouldn't be wrong if you actually call this. But again, the bell rings here, young patient, gastric location, epithelioid morphology, and they actually had done an NGS which didn't show any of these driver mutations, and this indeed was SDHB mutant. So therefore, imatinib which was given wasn't helping this patient, and they would have had to switch to a different tyrosine kinase inhibitor. So SDH mutation status provides vital prognostic information. In both paragangliomas and GIST, risk of a lymph node metastasis is increased if you have an SDH mutant status. As I said, imatinib resistance if it's GIST which has been given imatinib. And morphology clues and next generation IHC, again, information far beyond just the diagnosis. But it's the morphology which is, again, paramount. From this, I quickly switch over to my Castleman part of the story. A little bit on Dr. Benjamin Castleman. He was an American physician, pathologist, best known for describing the eponymous Castleman's disease. He also undertook clinical pathological investigations of parathyroid disease. He wrote several papers on thymus and mediastinal disease as well. In passing, Dr. Castleman succumbed to lymphoma in 1982. So here's a case which I'm going to illustrate Castleman's disease for you. It's a 30-year-old male who had HIV. He's on antiretroviral therapy. He developed generalized lymphadenopathy, and one of his enlarged cervical lymph nodes was biopsied. So here's a 30-year-old male. You can see the lymph node slightly pale here, so I'm not sure if you're going to appreciate the H&E too well, but there's a hilum. The section has passed through the hilum of the lymph node. You can see CD20 and a CD3. So CD20 is highlighting follicle germinal centers of varying sizes. And you can see that some of these sinuses are still patent, which is an important point that you should actually look for in Castleman's disease, at least the non-hyaline vascular types, because there the sinuses are obliterated. You can see that CD3 highlights a certain proportion of T cells in that interfollicular region. CD23 highlights the FTC, very tight FTC meshworks within the follicle germinal centers. But what's really interesting is on the extreme right, you're seeing this CD38, sheets of plasma cells in the interfollicular region. So there are less T cells, but more of plasma cells here. Now this is the IHC for P24 GAC protein. It decorates the dendritic processes of the FTCs. This patient is HIV positive, and this actually just confirms that it is an HIV infection. So on high power or intermediate power, what you're seeing is a mixed appearance of germinal centers. Some of them are actually hyperplastic here, and some of them are regressed or atretic. On the right side here is the hyperplastic germinal center with prominent mantle zones arranged in an onion peeling pattern. And on the bottom right side is the interfollicular region showing sheets of plasma cells. So here's a HIV positive individual. You're seeing this kind of a mixed pattern of regress follicles, hyperplastic follicles, interfollicular plasmacytosis. What should ring a bell is the possibility of a plasma cell rich Castleman disease. There's a very important finding in these HIV individuals who have this Castleman disease is the phenomena of follicle dissolution, which means that the boundary between the mantle and the interfollicular region becomes very blurred. The follicle becomes atretic, and here you can see all the prominent plump cells in the middle of the image are actually all FTCs, so they're just follicular dendritic cells. And there's increased vascularity along with plasmacytosis in the interfollicular region. Now here's the CD38 we saw. Is it anything to worry about in terms of is it a plasmacytoma? Well, it is not. When you do the kappa and lambda staining, there's no light chain restriction. If at all, there is a little bit of lambda light chain excess, but no light chain restriction. But there are certain features that were there in this. And when you're thinking of an HHV8 positive disease in a HIV positive individual with a Castleman-like picture, these are what have been, the arrows point to cells which have been described as plasmablasts. The plasmablast term was originally coined by Isaacson when they saw these cells within the mantle zones of these HIV positive individuals. They look like immunoblasts, big lymphoid cells with prominent nuclei, and on the right side they're also seen in the interfollicular region. So suspicion for this should trigger the investigation for an HHV8. On the left is the MUM1, which is a plasma cell stain, and use that to show you the nuclear positivity for these big cells in the mantle cell, in the mantle zone. And on the right side is the HHV8 LANA protein, which individually is marking all those large cells which are there in the mantle cell. So these are all HHV8 infected plasmablasts within the mantle zones. And when you do a kappa lambda investigation for this, something very peculiar, these cells are almost always IgM lambda. And you can see this kappa here being negative. Here's a low power, it shows that kappas are negative. It's marking the interfollicular plasma cells. But when you look at the lambda, and this is lambda-ish, it's showing you positivity for all these plasmablasts. You can see on the low power here. So that's something very peculiar. The plasmablasts in HHV8 associated plasma cell rich Castleman disease are almost always IgM lambda. This is a high power again showing you lambda restricted plasmablasts. Here's a snapshot of these cells. So MUM1 on the left showing you positivity. The lambda, again, as I said, HHV8 is positive. Remember that these will almost always be negative for EBV. EBV here is marking maybe 3 or 4 cells, and these are in the small lymphoid cells and not in the plasmablasts. That's the very typical IgM expression. IgM, lambda, HHV8, and EBV negative that defines the plasmablasts. IgD, which highlights the mantle, is negative in these large cells. These strangely mark with OCT2, which is a B cell transcription factor, but they do not express PAX5. The PAX5 is slightly difficult to identify because all the mantle cells will mark with it. OCT2 doesn't mark all those mantle cells, so it's slightly easier to interpret. And there's something also peculiar in this lymph node. There was a small bump here, if you can identify, and that's this bump here. And if you can see here on high power, amidst these plasma cells are all these vascular proliferation with slit-like spaces. And this, all slit-like spaces, the endothelial cells marked with HHV8. So this patient not only has Castleman disease with plasmablast, but he also has a Kaposi sarcoma associated with that. He has the lymph node capsule, which is markedly thickened, almost going inside like a trabeculum. And you can identify this, things are all marking with HHV8. That's the Kaposi sarcoma, which is actually going down the lymph node capsule. Also, incidentally, you can identify, look at this expanded hyperplastic follicle, the thick mantle, this buckshot pattern of HHV8 positive cells. So that's a plasmablast along with the Kaposi sarcoma on the right. There was another focus of Kaposi sarcoma. This is near the hilum. You can see this very congested area here. And these cells are all Kaposi sarcoma cells, ERG being a vascular marker highlighting that. And again on the top right, HHV8 marking these cells. So in a HIV positive patient, this is an HHV8 associated multicentric Castleman disease. Remember, he had generalized lymphadenopathy. This is the plasma cell variant, and there is an associated Kaposi sarcoma as well. So what are the features that lead you to this? As marked interfollicular plasmacytosis, there is increased vascularity. There is both follicular hyperplasia and regression. And these are the defining features of the plasma cell variant of Castleman disease. The HHV8 positive subset also has a distinct feature of follicle dissolution, which I mentioned to you what it was, and that's usually not seen with the other plasma cell variants of Castleman disease. This dissolution is accompanied by a marked tropism of virally infected plasmablastic or immunoblastic lymphocytes in the mantle zones, and you typically see sinuses being patent. They're not obliterated in the plasma cell variant. And if you want to read about this dissolution of lymphoid follicle, it's a nice paper in the AJSP 2003. Now, for this, something very peculiar is that the interfollicular plasma cells are polytypic here, but as I kind of mentioned, the plasma blasts themselves are monotypic. They are IgM lambda. But the thing is that when you actually do the gene receptor rearrangements, they are never clonal. So they are monotypic, but they are polyclonal. So they are not. So that's some kind of aberrancy here, that when you say that, it's not really a clonal disease. Okay, I'm just going to quickly go through in 5 minutes. Is that okay? Okay, thank you. So I will skip that. I talked about this monotypic lambda light chain expression. I'm going to skip this history of Castleman's disease. But here's very important. Nowadays, you don't look for highly vascular or plasma cell rich variant. The way you're supposed to distinguish between Castleman disease is unicentric versus multicentric. The unicentric can be would be highly vascular in 90% of the cases. 10% are plasma cell rich diseases. Multicentric, either it's HHV8 associated or HHV8 negative. The HHV8 associated might be HIV positive, but remember there will be HIV negative patients which can also have an HHV8 association. So do not hold back from investigating for HHV8 if the patient is not HIV positive. The ones which are HHV8 negative, which are not HIV positive, are called as idiopathic multicentric Castleman disease. They may be associated with the syndrome called TAFRO. And lastly, you can have an HHV8 negative POEMS associated Castleman disease. On the left side is the hyaline vascular pathology. If you have the unicentric one, that has more of hyaline vascular disease with regressed germinal centers, FDC prominence and vascularity. And on the right side, when you have this, you can have both regressed follicles versus hyperplastic follicles, but always you will see plasmacytosis in that. So here's one quick case. This is a 59-year-old male, generalized lymph nodes. He had peripheral neuropathy and he had a lambda monoclonal gammopathy. He had no bony lesions and he was not HIV positive. No distinct M band, but immunofixation revealed a lambda light chain restriction, and free kappa and lambda showed free lambda light chain increase. So here's a lymph node. You can again see the 20 and the 3. And what this also showed was a mixed pattern of hyaline vascular and a plasma cell thing. But, okay, also there is a very important feature of a twinning of the lymphoid follicle here, which means that the mantle is lost and both the germinal centers come together. That's a very typical feature that you see in hyaline vascular Castleman disease. But unlike that, there was sheets of plasma cells in this lymph node with no vascular proliferation. And 23 highlights the FTC meshwork, which shows very dense, thick mantle cell layer and the increased FTC meshwork. So while they did see in the immunofixation lambda light chain excess, we also got on immunohistochemistry lambda restriction, and this was completely IgA. So it's IgA lambda monoclonal proliferation. So this was an HHV8 negative multicentric plasma cell variant of Castleman disease, or the idiopathic MCD, which is what it is called now. So this particular variant can show you features of both hyaline vascular variant and the plasma cell variants. However, it generally presents with marked plasmacytosis and a lesser degree of vascular proliferation. And that's in comparison to the hyaline vascular variants. The sinuses again are rarely obliterated. They're almost always obliterated in the hyaline vascular variant. Now, it's also characterized by pro-inflammatory hypercytokinemia. Now, the reasons that multicentric Castleman disease patients have B symptoms is because of the increased cytokine secretion, particularly IL-6. So, last couple of slides, this is how even the clinicians kind of go about Castleman-like lymph node features. they will like to see clinically unicentric versus clinically multicentric. If it's multicentric, you want to exclude diseases like autoimmune diseases or an HIV disease or an EBV positive disease. And then they use either it's POEMS associated or HHV8 associated. If not, then it's an idiopathic multicentric Castleman disease. And this is a nice paper in Blood which actually shows you, these are images of on the, starting from the left side, the A shows you regressed germinal centers, FDC prominence, increased vascularity, and then when you have hyperplastic germinal centers with plasmacytosis, they've given a whole bunch of pictures on this. If you want to see them, it's a good paper in Blood 2017. This is my last slide, and this is something which has always intrigued me as to a lot of these so-called monotypic proliferations which are actually polyclonal are almost always have the lambda restriction. And to date, nobody has a very definite answer for that. So there have been hypotheses proposed saying there is a preferential targeting of the lambda light chain expressing B cells by HHV8 viruses or selective expansion of lambda light chain expressing B cells in response to viral infection. But this kind of didn't hold its water when they said it PEL, you actually get a lot of kappa restriction as well, and that's also associated with HHV8 and EBV. A study using ex vivo HHV8 infection of tonsillar cells showed that latent HHV8 infected cells were overwhelmingly enriched in the lambda than the kappa subset. Again, no great explanation as to why. Now, recent studies have demonstrated that generation of lambda light chain positive B cells is dependent on the NF-kappa B signaling during normal B cell development. Again, doesn't explain why you get terribly more kappa cells and lambda cells. But intrinsic viral effects, viral proteins like flip proteins from HHV8 could also be implicated in this enigmatic predilection of lambda cells, particularly in the multicentric Castleman disease. So I hope I've been able to explain to you about the enzyme deficiencies, the Castlemans, and that now we need to understand its unicentric versus multicentric and then try to do the histologic classification. Thank you very much for your patient hearing.